I'm Monty Mythen, Editor-in-Chief of Top Med Talk. Welcome to Journal Club. Top Med Talk.
Hello, I'm Desiree Chappell, and this is Top Med Talk. I'm here with Monty Mythen, Editor-in-Chief.
Thanks, Desiree.
I'd like to introduce our first two guests, and the first one is Barbara Slawski. She is the Director of the Perioperative Medicine Summit and an internal medicine physician from the Medical College of Wisconsin. And we also have Dr. Stephen Cohn. He's the Co-Director of the Perioperative Summit as well, and an internal medicine physician from the University of Miami, the Miller School of Medicine. So thank you, Dr. Slawski and Dr. Cohn.
We were discussing a moment ago about a couple of the takeaways with regards to the meta-analysis about ACE and ARBs. My takeaway in it was that it seems to be the right thing to do to stop the ACE and ARBs, because there was no harm associated with stopping the ACE and ARBs, but there was more hypotension if you kept the ACE and ARBs going. Was that right, Stephen?
I believe that's correct.
So now we have to accept as meta-analysis, etc.
Right. There's an ongoing controversy in terms of what we should do with this and the anesthesia. When I was in New York, I almost never stopped ACEs and ARBs. In all the years I was there, nobody complained it was a problem. And then I got down to Miami, and they said, oh, no, you can't give these drugs at all. So what we've done, and I think I highlighted that in the little small RCT that I presented, was that clearly it's associated with more intraoperative hypotension. So if you stop it, you'll prevent some of that. However, patients who were excluded from that trial and patients that we were more concerned with stopping were patients with heart failure or patients with uncontrolled hypertension. We don't want somebody canceled because the blood pressure is high, and some of the patients may be so fragile that they may potentially have a problem if you discontinue the drug, certainly 24 hours or more before. Holding the morning dose probably is okay, but again, we just don't have enough hard evidence for me to say that.
I think that there is a large RCT certainly going on in the UK, where Gareth Ackland is the principal investigator. It's been quite well funded. I don't know how far advanced it is. It wasn't in your lecture and maybe not often talked about. When do you restart? Do you have any restarting rules?
Well, they should be restarted, we say, as soon as possible when the patient is hemodynamically stable post-op. I would say the next day or certainly the day after that, and there is some evidence that if they're not restarted within either a 14-day period or a 30-day period, they've been associated with poor outcomes, increased mortality from VA studies.
Because one of our experiences with enhanced recovery is as we're getting everybody up immediately post-operatively, and many patients have orthostatic hypotension, as the ACE and the ARBs often don't help then. So we've switched to the sort of can they mobilize before we... Is that reasonable? I
think it's reasonable. I would say that should happen within 48 hours. So I think that being off the drug for a couple of days is probably not going to be harmful.
May I ask one more question on that
please.
session?
Yeah.
So we were also reflecting on the fact that there's no association between the ACE-associated hypotension and poor outcome, whereas the next study you presented, which is another analysis from Vision, I think, Abbott et al., A&A June 2018, MINS defined as a troponin of greater than 0.03 nanograms per mil, etc., all familiar with that. Tachycardia and hypotension, this time with a systolic of 100, was associated with a poor outcome. So there seems to be a disconnect between those two observations. Is that a numbers thing?
I think it's a numbers thing to start with, because they do have different numbers, whether it's systolic less than 100, less than 90, less than 80, less than 60, whether you want to look at just that or whether you want to look at mean pressures. And I think that's going to be a potential problem when you try to compare one study to another. The other thing from the Vision study, I believe, is that it did show potential for harm, but it was a composite endpoint including MINS, and it barely made statistical significance, whereas none of the individual components were statistically significant. And if you substituted MI for MINS, the whole composite was not even statistically significant. So again, a lot of controversy. What should we do? It would be nice to have that randomized controlled trial where we know what's what and we have a defined number for hypotension and complications.
Yeah.
And we'll add one more, but this time it's for Barbara.
Do it. Yeah.
I think it was in your session, Barbara, was the aspirin.
Yes.
Which aspirin?
Yeah, the aspirin.
Aspirin versus the DOAC.
Because we were talking about the DOACs, we went through the other trials, but in particular, I think you presented the results of a large observational study from Denmark, I think it was. Is that right? Retrospective, 42,000 patients, primary total
the
knee.
total knee arthroplasty and VTE prophylaxis, yes.
And what I took from that was aspirin seems pretty good as a
non-inferior in that study, yes.
Can you expand on the study a little bit more, so just so I'm clear as to what my real takeaway should be and how it might change my practice?
So this was a study where this was actually in the Michigan Arthroplasty Registry.
Okay,
if we're talking about the VTE
Yeah.
prophylaxis one, where the authors or the clinicians in this study used the American Academy of Orthopaedic Surgery guidelines, and they could choose between aspirin or anticoagulants as their choice of VTE prophylaxis. So the authors lumped any anticoagulant into a single group and compared that to aspirin as, for VTE prophylaxis for efficacy. The baseline characteristics of the study populations were a little bit different. As far as the number of bleeding disorders and VTE history between the groups. So that's a limitation of this study. But between aspirin-treated patients and anticoagulant-treated patients, there was no significant difference. So they concluded that aspirin was non-inferior.
So I wrote down, I think the PE, DVT, the bad outcomes related to clotting was about 4.8% in the none and 1.2 to 1.4%, but about the same in the aspirin and the anticoagulated one. But there was some baseline imbalance. I've not seen, where I've worked, aspirin being used as one of the options for DVT prophylaxis. Is it common?
It's very common in the United States, and actually, at least in this Michigan study, in 2015, the use of aspirin in total knees exceeded the use of anticoagulants, which I don't know if Stephen sees that at his hospital, but it's extraordinarily common at ours now. The surgeons seem to prefer this.
Interesting.
There have been some other studies, though, preceding this one, looking at anticoagulants and aspirin. And what's interesting about those studies, there was one with low molecular weight heparin that was given for 10 days, and then patients were randomized to aspirin or low molecular weight heparin in total joint. The other one was rivaroxaban, where patients took that for 5 days. Then they were randomized to either aspirin or rivaroxaban, and aspirin was non-inferior, but you have to remember that they received that anticoagulant drug before randomization.
Gotcha.
So this is the only one I've seen that compared aspirin truly to anticoagulation.
I think that's a good point, because people tend to misinterpret the studies, and they see, aspirin was non-inferior to low molecular weight heparin, non-inferior to
it was rivaroxaban.
But if you look at the patients, they did not get aspirin all the way, and the orthopods, this is based in Canada, I think, to start with, if it was a high-risk patient, previous DVT or things like that, they did not want to use aspirin. So they would still use low molecular weight heparin or one of the DOACs.
Yeah. Talking about all the evidence, and we talk a lot about translating evidence into practice and how to. I think that's one topic we need to start talking about too. Is like, how do you decipher the different studies, and what are you going to use in practice and what are you not, and what's a good study and what's not? Because I think a lot of providers, there are some that come from academics that are really good at that, but there are a lot of people in community facilities that just will read titles and not necessarily do deeper dives.
So we've taken that at our facility with Total Joint, where we have a very close relationship with the orthopedic joint group, and said, okay, aspirin's okay in your general patient. We're going to give you that because we're not going to stop them from using aspirin.
Yeah.
But here's the protocol as far as what the dose we find acceptable is, what the formulation is, and here's the patients where we don't want you to use aspirin. So we've basically picked our battles.
Yeah,
so patients with a significant thrombophilia, patients with cancer, patients with a family history of VTE. And when we just pick that group of patients we view at the highest risk, the orthopedic surgeons will basically listen to us and say, okay, for those patients, we won't use aspirin, we'll use an anticoagulant agent for VTE prophylaxis.
Yeah, that's a really good point, picking your battles, for sure.
One of the things I mentioned this morning on the risk calculators is you see a lot of articles are comparing them, saying, oh, this one's better, this one's not better, and most people do not understand how they were derived, what their complications were, and therefore they misuse the risk calculators. So it's the same kind of thing. The anesthesiology paper that came out had an editorial that said you can't compare apples and oranges sources necessarily, but most people won't read the editorial.
Yeah,
They'll just read the first take.
I like that you said that, for sure.
Top Med Talk.
Nick Majerison here. Thanks for listening to Top Med Talk. Now all you need to do is find us on social media. We can be friends on Facebook. We can follow each other on Twitter. We can hang out on Instagram. Or we can even gorp at each other on YouTube. Get onto your social media platform, whichever your favourite is, and you're likely to find Top Med Talk there. Whilst you're at it, make sure you've subscribed to this podcast so you never ever miss an episode. Helps us enormously if you do that, by the way. And check out the website, topmedtalk.com. On there you can find the email updates where we update you as to what we're doing each week. And whilst you're online, whilst you're doing your thing on the internet, I highly recommend you download all of the podcasts that we've put out here on Top Med Talk. We do an enormous amount of material here. A lot of it is incredibly valuable and, of course, will be in the future. So I just recommend you download the entire back catalogue if you could. Helps us out if you do that as well. And check out ebpom.org/meetings, because if you go on there, you can find out where we're recording and what we're doing, because we go to the big meetings, the EBPOM meetings. You may have noticed most of our material comes from some of these wonderful conferences that are organised by evidence-based perioperative medicine. So EBPOM, ebpom.org/meetings. Get yourself on there, and why not check out the Dallas Masters course, a perioperative care practicum. Hopefully I'll see you there.